It's with great pleasure to have you all this morning. Thank you for the early morning, and I'm very honored to introduce Dr. Dominguez Gil, who's come from Spain as one of the leaders in organ and tissue donation in the world. She's a nephrologist by initial trade, also has her PhD in internal medicine, and after several years working, she decided to move into clinical research and then join the medical team for one of the largest and best run organ and tissue donation organizations, the ONT, which is the Spanish National Transplant Organization since 2006. There are a number of accolades and numerous research publications, and really one of the founders of bridging the clinical experience and the research and data experience to bring science to the art of donation. Currently, she's a counselor at the Europe at the Transplantation Society, and chairs actually the ethics committee, and has been the past chair of the European Donation and Transplant Coordination Organization. So she has very big shoes in the international stage, and really has led practice. And today she's going to tell us more about that. And we're really thankful to have her, so please give her a warm welcome. Thank you very much.
Good morning, everybody. Thank you, Sunny, for your introduction. I would like to thank the organizers for being here today. I will try to show you the way we do things in Spain, but I'm actually learning more from you than I think you will learn from me, but I'll do my best. I would like to particularly thank Dr. Sam Semi and Andrew Haley for their invitation. So let me start by referring to the global activity in organ donation and transplantation. These are data from the Global Observatory, where you can see how every year we performed about 120,000 solid organ transplants, which is an impressive activity. But when we take a look in detail to these numbers, you can see that many are performed in breach of the Hippocratic principle, primum non nocere. We use a lot of live organ donors, and the WHO estimates that we are barely able to cover 10% of the global needs of transplantation. You all know the consequences of shortage of organ. Quality of life is poor, many patients die on the waiting list, great cost for the healthcare system, and organ trafficking and transplant tourism as a consequence of that. So, concerned about the growing need of organs for transplantation and exploitative actions against the destitute and the vulnerable, in May 2010, the World Health Assembly issued Resolution 6322, by which it called countries to enforce, to strengthen national capacities, oversight of donation and transplantation activities in countries, with particular emphasis on maximizing donation from the deceased. We consider that in Spain somehow we anticipated the call that the WHO would launch 20 years later. In 1989, the Spanish Ministry of Health founded the Spanish National Transplant Organization, ONT. ONT is embedded within the Ministry of Health. It belongs to the Ministry of Health, and it was empowered with the oversight and coordination of donation and transplantation activities in the country, which is politically decentralized as yours, as Canada, but with a very good technical, legal, and healthcare background from the transplantation perspective. ONT agreed with the region a model of coordination of donation and transplantation activities that made the country evolve from about 15 donors per million population, 500 donors, to about 34 donors per million population, 1,500 donors a year in less than a decade. You can see how in a very short period of time we were able to reach somehow a worldwide privileged position in the world. This is the map of disease donation per million population in WHO member states, where you can see how Spain, with all the European countries and the US, has that privileged position I was mentioning, with 40 donors per million population achieved in the year 2015. And what it is more important, we've been able to develop extraordinary transplantation activity. So the figures that we reached last year were well over 100 transplant procedures per million population. Well, what is the reason for the Spanish success? And I would like to take a few minutes to dismantle myths about the Spanish system. In the very first place, our population is not more prone to donate than others. This is a survey that was performed by the European Commission several years ago, and to the simple question, would you donate your organs after death, this was the situation of Spain. A survey that made evident that there was no correlation between how prone a population was to donate their organs and disease donation rates. So that's an important message in the very first place. Well, the second myth is about the opt-in out system or the presumed consent policy. Is it because of that? Well, we have to say that having a presumed consent policy, for us, it is an example of societal compromise with organ donation. We have universal access for transplantation, so the normal thing to happen is that people contribute to organ donation, not that they do not contribute. However, in practice, we do not practice a hard presumed consent policy, as here in Canada, the families are approached always. We try to find out with the families what the wishes of that individual were about organ donation, and the family has the final veto, so they can override also the will of their beloved one. And importantly, our disease donation rates started to increase much later after we issued this legislation in the year 1979. So we don't believe it is the presumed consent policy, although overall it helps to create a climate pro-organ donation. Another important myth is that we are very poor drivers, and it might be the case, but actually we were not that bad. These are mortality rates relevant to organ donation in European countries, where you can see how they are progressively declining in basically all countries. And guess what? We are here. We actually have one of the lowest mortalities relevant to organ donation in Europe and in the world. So it's not that we have many possible organ donors in the country. Now, you would say, but you have many ICU beds to admit these patients, do you? Well, yes, we have good ICU resources, we have quite a significant number of ICU beds, but we're not the most outstanding countries, at least in Europe, in terms of the availability of ICU resources to admit patients, for example, to enable organ donation to happen, which is a practice in our country, by the way, as you will see immediately after. This is a classic slide. I'm sure Sonny remembers this one. We never engaged into what it has been, or we can consider classical methods to increase organ donation. We haven't invested in promotional campaigns. There are systems in place for people to express their will about organ donation, but we don't invest our time or our resources to promote these sort of initiatives. When a politician wants to fix organ donation, they always say, we will make a big promotional campaign. In our view, that's a complacent situation for a politician who blames the population when it is the system, it is the professionals, the one who fail. It's not the public. The public will likely be donating their organs. It is the system what fails. So it is only a matter of organization according to your reality, your legal reality, your healthcare reality. It is a matter of organizing yourselves. And we found a model that worked very well in our country. It might not be reproducible entirely in other systems, but it worked in our reality. The elements of the Spanish model have been widely described in the literature. I'm going to go very quickly across them, but it is a matter of selecting the right professionals who, in our view, are you, the intensive care doctors. They take care of organ donation. They're providing with guidance. They are evaluated in terms of performance. They are supported continuously by the national and the regional agencies. And we have a specific way of working with the public through the mass media, not through promotional campaigns. So let's go through all these elements. This is our donor coordination network. We are organized at 3 different levels. As you hear, the national level is represented by ONT. The regional level is represented by our 17 regional offices. ONT and the regional offices act in support of the process of organ donation, and they report to the national and the regional healthcare authorities, respectively. And then we have a network of hospitals which are specifically authorized for organ procurement, and every one of these hospitals has an in-house donor coordination team. As here in Canada, as I said before, we are a very decentralized country. We have to align regional policies. So we have a national transplant committee with representation of ONT and the different regions to align oral policies in donation and transplantation. At present, very quickly, our network of hospitals in a country of 47 million people is of 189 hospitals, which I think is quite lower number compared to yours in Canada, as I learned yesterday. The most important thing is our donor coordination profile. So in the hospitals, we have these teams which are always led by doctors, and particularly by intensive care doctors, and supported by nurses. That's the composition of the hospital coordination unit. These doctors, importantly, are part-time dedicated to the donation activity, so they develop their normal clinical activity in an ICU, caring for patients. They are part-time dedicated to the donor coordination activity. They are empowered in the hospital. They do not report to the head of the transplant unit. They do not report to an external agency. They directly report to the director of the hospital. So they are empowered in the hospital to make organ donation happen. I think we're going to spend a little bit more of time about the composition of the donor coordination teams, and here you have the number of doctors and the number of nurses, but importantly, among doctors, you can see how at present 88% of them are intensive care doctors. Possibly, the fact that these intensive care doctors were designated as donor coordinators was creating in the intensive care community sense of responsibility in organ donation. I'm going to give you 3 examples of that sense of responsibility. This is the Code of Ethics of the Spanish Society of Intensive Care Medicine, where intensive care doctors state that society claims for their participation in organ donation, and they feel responsible of making organ donation happen in all the different phases of the process. This is the list of indicators of quality in intensive care, which is issued by the Spanish Society of Intensive Care Medicine on a periodical basis. And among key indicators of quality in intensive care, not quality in organ donation, quality in intensive care, they have identified the identification of potential organ donors and the conversion of potential into actual organ donors. So if you have a good ICU, you have good indicators in organ donation as well. And finally, quite recently, the Spanish Society of Intensive Care Medicine has issued 5 high-level recommendations in different areas, and these were the ones that they produced in organ donation. A donation should be an integral part of end-of-life care, and this is said by the Spanish Society of Intensive Care Medicine, and it needs to happen whatever the circumstances of death, whether that patient is in a brain death condition, whether the decision has been made to withdraw life-sustaining therapy on the grounds of futility, or whether the decision has been made not to initiate intensive care with a therapeutic purpose. In all those circumstances, organ donation should be considered. The third element is ONT. We are the organ sharing office for the country, but we consider us as a support agency for every one of the processes that occur in the country and for the process of deceased organ donation as a whole. One of our key programs is this one, the Quality Assurance Program in Deceased Donation, which is running since the year 1999, and which consists on a continuous audit of all deaths who occur in intensive care units in the country to identify persons likely to be in a brain death condition, and we analyze the reasons why they don't transition to be actual organ donors. You can see here how medical unsuitability is a very frequent reason for that. Importantly, we perform external audits to the hospitals, not to all hospitals every year, but to selected groups of hospitals, in which external auditors provide recommendations for improvement to the donor coordination team and to the hospital managers, because the idea is that the hospital managers also support the donor coordination team in performing measures for improvement. Training is never enough, and this is the fifth element of our system. We have been training everybody who has to do anything with organ donation: donor coordinators, emergency care doctor, intensive care doctors, neurologists, particularly those who work in the stroke units. And we have different type of courses, particularly for the family approach. We have developed a system, a training module on communication in critical situations, which is not targeted only to organ donation, but to cover the learning gap of healthcare professionals in communicating with families. And this is supported and budgeted by the Spanish government. So far, we have been training more than 16,000 healthcare professionals in the country in issues related to organ donation. The media is our ally in promoting organ donation. As I said before, we don't invest in promotional campaigns. We work with the media, always available to them through a 24-hour available telephone with a doctor and a director, easily accessible to these professionals. We have specific meetings with journalists every year to learn from mutual needs. And we always transmit messages without intermediaries and with one spokesperson if possible. And finally, this is properly reimbursed by the healthcare system. Human and material resources needed to develop the donation, procurement, and transplantation activities are covered by our system. But I want to dedicate some part of my presentation to tell you about the challenges that we have been facing over the last few years to keep our level of donation and transplantation and even to improve. And I think some of these challenges might be shared with the Canadian system. This is the evolution of brain death in our country. The incidence of brain death is dramatically declining in the country as it is occurring in Canada. This is possibly because of the reduction in the incidence of events leading to devastating brain injury, decompressive craniectomy, and as I will say later on, because of changes in end-of-life care practices. But curiously here, you see that actual DVD donors have remained rather stable, so it seems that we are getting better and better in converting potential into actual DVD donors. But this decline in the incidence of brain death made it imperative to look for alternative ways of increasing organ availability. Also, we have experienced very important changes in end-of-life care practices in the country. I'm sure you are familiar with this study, which was published at the beginning of the century by the European Society of Intensive Care Medicine, and that described the circumstances of deaths of patients in European ICUs. And there was a gradient from south to north or vice versa. So, for example, the incidence of brain death or the probability of dying in a brain death condition was significantly higher in South Europe compared to North Europe, and to the contrary, the probability of dying following the withdrawal of life-sustaining therapy was very frequent in North Europe compared to South Europe, where this was a relatively rare event. This table possibly reveals differences in professional practices that are influenced by educational issues, social, religious issues. We don't know the reason behind, but the truth is that professionals in South Europe are more prone to keep intensive care beyond futility or to withdraw life-sustaining therapy later than professionals in North Europe. And that was the situation at the beginning of the century in our country, so possibly we didn't have potential control DCD donors. But of course, this is a picture that was taken at a specific moment in time and that did nothing to do with what would occur later. In 2008, the Spanish Society of Intensive Care Medicine published these recommendations about end of life of the critical patient, where they were very clear that maintaining treatment beyond futility, which was a normal practice in South Europe, was against human dignity and was against the principle of distributive justice. So this document somehow was a prelude that end-of-life care practices were going to be changing in our country. And in fact, they did. There were numerous studies which revealed that many patients in our ICUs were now dying following different types of withdrawal of life-sustaining therapy. This is a study which was published very close to that document that I showed you before, in which already 55% of our patients in ICUs were dying under these circumstances. And we had a moratorium on controlled DCD since the year 1996. Surprisingly, not on uncontrolled DCD, which I think is your case here, but on controlled DCD. Our intensive care doctors were very afraid of being perceived as being deciding on the withdrawal of life-sustaining therapy because of organ donation and not as separate decisions. So if this was the situation of our country, we really needed to move forward. And of course, it's very difficult to change practices and to move outside of our comfort zone. We could keep doing things the way we were doing them until now, but we could make a good movement forward. So in 2008, we devised what we call the 40 donors per million population plan, which is focused on 5 different initiatives. But in the interest of time, I'm just going to talk about the 3 of them that had been critical for us to reach that level of organ donation, 40 donors per million population. The first one is intensive care to facilitate organ donation. What is that? Well, this is a graph that shows that many factors are going to be determining that a patient with a devastating brain injury dies in conditions consistent with organ donation. They need to be intubated, ventilated, they need to be in an intensive care unit, and of course we can keep with the potential which is inside the ICU, or we can go outside to the emergency department or to the hospital ward and modify admission criteria to the ICU and modify clinical practices. It was a long process, but we were able to identify through a benchmarking strategy hospitals that were outstanding in the identification and referral of patients from outside of the intensive care unit to the ICU with the intention of organ donation. We visited these hospitals and we came up with this finding that these hospitals, which were reaching extraordinary levels of disease donation, like 70 donors per million population, had devised in their pathway of care of the neurocritical patient organ donation at the moment when the team was shifting from active treatment to palliative and end-of-life care. No matter whether that patient was in the ICU or not, no matter whether that patient was under mechanical ventilation or not, organ donation was routinely considered and discussed with the family, and if needed, intensive care to facilitate organ donation was applied, and that patient was admitted to the ICU with consideration about a timing in which we would wait for brain death to happen. We have been working in this area for several years, and we have here 2 important documents in this regard. This is a document which is targeted on the topic to emergency care doctors, and we are now preparing this with the Spanish Society of Intensive Care Medicine. The concept is difficult, it's challenging, but it is a matter of considering organ donation even at that moment in which the decision has been made not to initiate intensive care with a therapeutic purpose, but to do so because of utility, but to do so in order to enable organ donation and particularly donation after brain death to happen. This has been subject of intensive training. To give you an idea, just with emergency care, we have trained more than 7,000 doctors in the identification of possible organ donors in the emergency department and in this concept of intensive care to facilitate organ donation. And at present, this is a recent study where we have evaluated the circumstances of death of patients in our hospitals as a result of a devastating brain injury. 10% of them have been admitted to the ICU to enable organ donation, to incorporate organ donation into the end-of-life care pathway, and importantly, they contribute to 24% of our actual organ donors. So without this practice, our actual donation rates would be 24% lower. Another area of work have been the expanded and non-standard risk donor. We don't have time to go into the details, but we have been adapting ourselves to the new profile of the potential organ donor. So we have been progressively expanding donor age in our selection criteria. For you to have an idea, in 2015, 50% of our donors were over 60, 30% of them were over 70, and 10% of them were over 80. And they are substantially contributing to transplantation activities. They are never going to provide you the same results than young donors, but they will give you a lot of advantages, particularly for old recipients. These are their contributions to transplantation activities. So in a 5-year period, you can see how 40% of the kidney transplants and 50% of the liver transplants were performed with organs from aged or very aged donors. Well, last but not least, we have been working on DCD. Our classical type of DCD in red is uncontrolled DCD, donation from persons who have been declared dead following an unsuccessfully resuscitated cardiac arrest. This has been occurring in Spain since the 80s, and right now it represents about 6% of our disease donation activity. But as I told you before, we had a moratorium on the practice of controlled DCD since the year 1996, and this was decided to be changed on the basis of the different end-of-life care practices that were being described in our country. If patients were dying following the withdrawal of life-sustaining therapy, the system had the obligation to give these patients the opportunity to donate. And this has been the evolution of controlled DCD in the country. It has been increasing exponentially to the point that in 2016, we are expecting more than 500 DCD donors overall, and will represent 25% of our disease donation activity. So you can see here how, if you take a look to the DCD program in green and in red, we've been able, at a moment in which the potential of DBD was declining, to maintain the DBD activity intact for the time being and increase the overall disease donation activity to that target of 40 donors per million population. So in conclusion, the Spanish system is basically based on the organization around the process of disease donation according to our local reality and our possibilities. The Spanish approach has been partially or completely replicated in other realities with relative success. But importantly for our country and for many other countries, we're going to have to face very important challenges in the future. The transplantation needs of our patients are increasing, and the potential, particularly the potential of DBD, is going to decline. So we are confronting this situation with novel strategies inclusive of ICOD, intensive care to facilitate organ donation, expanded criteria donors, and DCD programs in Spain. Of course, this experience might not be completely applicable to your reality, but we believe that some of the ideas derived from these new strategies may help or inspire other countries as yours in moving forward in increasing the availability of deceased donor organs. The Spanish system is based on organization, but the second element of our system is innovation and adaptation to the change. And that's what I would like to finalize with this sentence from Winston Churchill, who stated that to improve is to change, but to be perfect is to change often. Thank you for your attention.
I do. So thank you, Dr. Dominguez Gil, for your great talk. We have time for maybe 1 or 2 questions. So I was impressed by the success of your external audits to improve organ donation. Can you give us more details on how you conduct those audits and how you translate your findings into clinical practice?
Yes, we perform every year audits to about 20 hospitals in the country. They are selected by the regional offices on the basis of those hospitals they consider they are amenable to improvement. The visits are organized with donor coordinators from a different region. They are provided with all the clinical charts and information about the audited period. And there is a joint activity between the local team, the local donor coordination team, and the auditors in understanding whether all brain death cases were identified and referred, and the reasons why they were not referred, and also the reasons why brain death cases did not transition to organ donation. They discuss whether, for example, medical contraindications were appropriate or not, whether a negative or a refusal to organ donation could have been reverted on the basis of the rationale provided by the family for that refusal, whether a maintenance problem was evidently avoidable. And that is formulated as local recommendations that are provided to the local team and to the managers of the hospital. Then the audited center needs to complete a survey of satisfaction about the audit system as well. So it's not managed, as I said before, as a police activity or a punishing activity, but as a learning opportunity for that hospital.